Welcome back to Starting with IEP. I am Flor Amelia, and this is episode number 24. If you're new here, this podcast exists to help parents understand special education decisions so you can advocate with confidence and not confusion. But before we get started, I want to invite you to visit us at www.startingwithiep.com. That's where you'll find our courses, parent resources, and advocacy tools designed to walk you step by step through this IEP process. Now, if this podcast has been helpful to you, please follow, like, share, comment. Your engagement definitely does help more families find this information. Today's episode focuses on a question that families have been asking. And the question is, why does OT eligibility look so different from one setting to another? This is not an episode about IDEA checklist or legal definitions. Instead, it's an honest conversation about the clinical reality behind the OT decision making. My guest, Cody, is a pediatric occupational therapist with experience on both school-based and private settings. Throughout this conversation, one theme keeps coming up. OT eligibility often depends on the therapist's training, experience, and how they interpret their role. We talked about the difference between compensatory and adaptive approaches versus restorative or rehabilitative skill building, and why schools often prioritize access and accommodation, while private therapy may dig deeper into underlying skills like motor planning, sequencing, visual processing, and regulation. This episode is not about blaming schools. It's about helping parents understand why outcomes can vary, even when a child's need may feel very clear at home. I absolutely know that you're going to love him. From the first conversation, I was like, he gets it, he understands it, and he can definitely help more families understand this process too. So again, please stay tuned. And in the notes, it'll also have his website and his contact information so you guys can reach out to him. So let's get into it. Hi, Cody. I'm so excited that you're here. I'm trying to contain all my excitement.
The feeling's mutual. I feel like even just in our brief conversation a few weeks ago, we were ready to dive in that moment. So I'm glad we were both able to step away, prepare a little bit, and hopefully that can be an asset to you and your community.
Yes. Oh my goodness. Yes. But before I start asking you all of my questions, I was wondering, can you please tell everyone more about yourself, like your background? How did you get there? What drove you to this field and what sustains you? What gives you that energy to stay? And also, if you can give the reason why I'm asking you for your educational background also is because we have a lot of families that they're interested in becoming an OT. So I think it would be a really nice guidance for them.
Yeah. And it's interesting. I just had this conversation. I was at a marketing event a few weeks ago, met a woman, and she was like, oh, my son would love to connect with you. He's going to college at Boston College out here in the greater Boston area. So I just connected with him, and true to form, I love occupational therapy, and it wasn't necessarily the path I started on. So I finished my undergraduate degree back in 2015, Westfield State University here in Massachusetts. That path was pretty traditional with most high school athletes. I went into my undergraduate training for more of an exercise science, sports medicine concentration. Pretty adamant I wanted to be on the physical therapy track. What eventually steered me into the field of occupational therapy was a series of just excellent mentors, combination of professors who encouraged me to go do some clinical observations, looking into the specifics of occupational therapy across different settings. And I think that's where not only I discovered that the field as a whole was much more my speed. One of the original professors who got me hooked on it, she's like, you're just way too social, way too quirky. You need to be an occupational therapist. According to her, I had one of those brains. And when I went on to do my master's program I graduated that in 2017, that's when coursework starts to get a little bit more specific into a lot of the concepts that I'm working with now, specifically with my private practice. I bounced across the lifespan a decent amount of my career. I started here in the greater Boston area doing geriatric care. A lot of occupational therapists or allied health professionals, I decided I wanted to do travel therapy. So that was a good 3-year chunk of my career where I went out to the West Coast in California. I worked at a few outpatient clinics right in the middle of COVID. I was at a rehab hospital, did a little bit of home health. And that's where the pediatric exposure really started to take flight. So when I first moved back to Massachusetts following all that travel time, I landed into a school contract. And after really immersing myself into that is when I ultimately started my private practice. practice. So emerging kids, pediatric occupational therapy is a concierge service. I contract with a few private schools in the greater Boston area right now. I would say 80% of the care that I provide is in home, whether it be after school visits. I have a small caseload of homeschooled students, so I'm able to see them in the middle of the day. And
You go to their home?
I go to their home. And the good thing about my operation is it's pretty flexible in the sense that New England is a little bit tricky to do this, but I've met at the community center or a park, things of that nature. I can't say we're doing that on a day like this in January where it's 20 degrees outside, but being able to use the community therapeutically and ultimately utilize what's in the home, because I'm the first to attest, like I love a sensory gym. I love the equipment that we're able to utilize for a lot of that sensory feedback. It's not always going to be accessible. If we're having some dysregulation in the grocery store or other community spaces, we're not going to be able to hop on a therapy swing. We're not going to be able to bounce on an exercise ball. What strategy, linear and tangible strategies can we utilize in that moment with what we have, which may just be a small space in our bodies?
I don't hear enough occupational therapists doing that in the community. So do you have like programs, maybe like videotaping so you can show other families? I know that you're not showing your clients, but
Right.
have you done videos that families can see how you model for them?
Totally. And right now that's been pretty private, but I took a course and that we can talk resources specifically in the sensory lens. But I recently took a continuing education course on video modeling and what are the benefits of having a child see those successes and play teacher for themselves. So I think in the course they give the example of what does it look like to put on your snowsuit? It's 7 different parts where I have to get my first layer on, then the jacket, manage the zipper, then the boots, tie it. But when the kids are involved and they have that voice, they see the success of what they're completing in that moment. It's just that the inner autonomy in the buy-in goes a long way. So looking into kind of my goals for 2026 is doing things exactly like this, moving outside of just withholding this information. How can we make a lot of these things as public as possible? What I can do is I can direct the listeners to a series of educational talks I'll be doing in the greater Boston area. Yeah. Not too many have virtual capabilities right now, but that's my hope within the confines of what I'm doing for myself within the practices to come out with some things on Instagram. And I can't quite will myself to get on TikTok just yet, but I've heard that's where I'll have a farther reach, if you will, to make the knowledge a bit more accessible.
Yes, because I think I'm already asking, how can we get more of you? It's because of our last conversation. Because of that conversation, I was like, I need to make sure that other families reach out to him, know of him, get more of him. You know what I mean?
Appreciate that. And I think above all, for me, it's advocacy for the field. A lot of occupational therapists share the views that I have. I'd say compared to some of the other allied health players, physical therapy, even speech therapy, people don't always conceptualize the full extent of what occupational therapy can do too. So that's very much my vision of getting, even I'll intermittently abbreviate it OT, but I found a lot of people don't even know what OT stands for.
If the audience doesn't know, we're going to have a part 2 and we'll definitely talk more about that. And in this first part, it's really important. I was in this IEP meeting and the family was just asking questions to really understand why eligibility wasn't there.
Let's see if we can get more info, more clarity.
Yes, because she disagreed. She asked for it to be in the PWN and we just have to collect more data. Everything is just a lot more data. Now that we understand your reasoning, we're going to collect more data. So I'm just so excited for her to hear this episode. And even they're just afraid to ask because they know sometimes how the school can react, like being that parent. So thank you again. We're going to dive in for these questions. This first part of questions are going to be more geared towards educational impact versus the clinical need. Can you please tell me, how do schools define the educational impact when determining OT eligibility? And how does that differ from clinical need in the private practice?
Yeah, and I think that was the main distinguishing factor. So as I said, I've done a bit of contract work in the public schools here in Massachusetts, and being able to provide some of that compare and contrast for private versus the scope of practice and what that really is in the school setting. Hopefully I can shed a little bit of light on that. In my experience, and I think the disclaimer that I will give is coming in as a contractor, for me, it likely was a little bit different of a process where I don't want to say I'm not as immersed into the culture of the school, because I feel like I was able to gravitate towards some really solid people and mentors in those settings. I think it's just a little bit different than being a hired salary employee. But from my observations, and I am sure this is consistent across state lines, is just thinking of eligibility to start, they go through that little flow state where they have the questionnaires to determine disability, diagnosis categories, and all of that. For the occupational therapy evaluation, it's a lot of standardized information. The specifics of what my interpretation of that is under Massachusetts IDEA, DESE, all of those kind of things, more or less comes down to the following categories. There is the sensory processing, where it's teacher feedback, and there's the informal interviews, the clinical observations, but there are standardized measures such as a sensory profile, sensory processing measure. That for me is very much a conversation piece, and it starts as more or less a checklist where there's some comparison to age-related norms and having the teacher's feedback of how does this one child compare to the group. All these standardized assessments, of course, are on that bell curve, and it's the determination of where the child falls within those things. So the sensory piece starts in that questionnaire platform, if you will. And then looking into some of the other standardized measures, there's the fine motor components, where looking at the anatomical makeup of how a child's able to hold and manipulate not just pencil, crayon, all of those things, but some of the other functional skills that are necessary for the academic day. And that's the language that a lot of the schools will utilize, is this needs to be related to the academic setting. I think where it can get a little bit tricky, there's a pretty broad scope of what occupational therapy can cover. And I think the general theme is interdisciplinary communication. When I go to an IEP meeting and I'm in those conversations for determining eligibility, I'm truly looking around the room and asking myself, and also asking the team, like, who truly is the best provider for this job? And that might vary from district to district based on providers training. I do a lot of collaboration with school counselors, speech therapists, and again, I think it all comes back to each individual school's interpretation of how the law is written, I guess, for lack of a better word.
Can I ask, when you were talking about the pencil grabbing, the crayon, so there was this, it was a middle schooler, and we noticed, we did a classroom observation, and they use a tablet. There's no pencil because they say, oh, a lot of the kids, they don't know how to write, so they don't offer pencil, they just offer the tablet, just like pointing. But I want my son to learn how to write. And then they were one of the occupational therapists, what he said, he can hold a pencil, but mom is like, but he doesn't know how to write. But then his rebuttal was, but he can hold a pencil. That's the whole writing to teach, that's the teacher's job. But holding, that's it. And then mom was like, he can't cut. And then the occupational therapist there was like, he can do the maneuver part of it, but teaching, that's his job. Same thing with gluing, because he's having difficulty processing, because he can squeeze the glue, but mom is like, yeah, he can squeeze the glue, but he doesn't know how to put glue on the paper, like focusing on the hand-eye coordination, then and putting it back where it's supposed to be, like that part. But the OT was just saying, he can do all of those parts, but that's not his job to teach the child, the students, how to do all that part. And that's why they like wouldn't do.
Sure. Yeah. And I think, what's the root why? So when I think of the term occupation in regards to occupational therapy, broadly, it's what occupies your time, specific in the academic setting. It's all of these skills that we just described, the cutting, the coloring, the gluing, all of those things. For me, I'm really looking at the individualized performance skills, which is pretty specific to the occupational therapy practice framework, where the performance skills are more or less how that task is broken down. When we're thinking of the example you just gave, we call it a classic color, cut, paste activity. What are all the things that need to go into that? We need to, yes, be able to hold the pencil, but we also need to be able to have the visual motor processing to potentially copy something. If I'm looking up at the board and I see my name, CODY, copying that onto whatever document I'm doing and be able to make those translations too. And looping back to what we said about the evaluation process, there's some standardized metrics for breaking down visual perception and visual discrimination into all these different subsets, where you can start fairly broadly in what I typically refer to as more screening tools. And then you can really get into the specifics of, is this visual memory? Is this visual spatial relations? All of the subtests that go into those everyday tasks. And given the nature of, I would say handwriting is probably one of the most prominent examples in the academic setting. And yes, we have this big push towards technology, typing tech, which is a great supplemental tool. At the end of the day, it's what I would call more an accommodation or compensatory, right? It's not rehabilitating what the underlying skill is. And I think in regards to public schools and just the way the law is written under IDEA, it doesn't really utilize the language of rehabilitation too much. So in the way that everyone kind of interprets it, they'll take that and run with it. And I don't want to say compensatory strategies and accommodations are Band-Aids, but how are we fixing the underlying difficulty?
I knew I liked you. Because that makes so much sense, because sometimes at schools, I see it sometimes like a bubble because they're like, they can't. I was like, yes, but when they have a job, is it going to be accessible for them at that job? Is the job going to have tablets?
Yeah, I don't know. And again, I wasn't at the table when all these laws were written. I think occupational therapy as a field would be a pretty strong advocate. And I don't want to get too derailed into this, but the absolute best model that I've ever seen, a little bit of context, back when I knew I wanted to make the transition into the pediatric world, I was interviewing before I ultimately decided to open my own practice. There's a school down in Rhode Island called the Wolf School, and I interviewed with them. I did get accepted, and the only reason I did not accept it was the geography. It just didn't make sense for us to move down there at the time. But when I went through it, it was one of the helpful things is one of the co-founders was an occupational therapist. So I knew that model was going to be built in. And I took a few notes here, but it's called the immersion model. And to me, it just makes the most sense. So I would encourage you to look into, you can find all of this on their website. So the immersion model, let me see if I wrote down this definition here. So each immersion team includes a certified special education teacher, a speech and language pathologist, an occupational therapist, and 1 to 2 teacher assistants who collaborate and work together to collectively meet each student's goals. The immersion model team holds informal meetings multiple times a week to assess student goals and create a seamless approach to learning. Together, the immersion model team establishes a strong classroom community where students feel confident to take academic and social risks and are capable of generalizing these skills across settings. That was like, yes, absolutely. Could not love this more. And when I went down to do a walkthrough there, they, true to form, they had all of these providers in the classroom at all times. And while they intermittently provided pull-out services, I think that ultimately, as it relates to the public schools, is it's a big deal to take kids out of class, right? Especially as ages get a little bit older, the academic demands get a little bit harder. I don't want to say it's harder to justify, but I think the method of delivery really needs to be intentional on how we're structuring it. And let's make this as practical as we can be, where it is more immersion model style, where the occupational therapist or other team members are seeing it in the moment, can actively collaborate with providers in the room. So it's very seamless, where I'm not a speech therapist, not my training, right? But if I can pick up on some strategies from my colleagues, so when I am working one-on-one with a student, there is that flow that you may not have when it is in more of a traditional pull-out. Every provider's going in their own direction. And I think for me, one of the biggest things that I'll push when I was doing my school contracts is the consultation of, I'm not just talking to the general education teacher, I'm looking into who the primary special educator is. I'm going into specials, lunchroom monitors, all of the people. So it's a connected being, if you will, where everyone is on the same page, knows what the IEP is, assuming there's eligibility, of course, knows what's in there, knows how it should be interpreted. So it can be as consistent as possible from the time that the kids are in the building.
I love that you shared that. And you said it's at
Wolf School in Providence, Rhode Island. This is private school.
I think it's so great that you shared that model, because then what parents need to do, they need to do what you said, go check it out. And then the families can be like an advocate as a whole and say, we need more of this. We need to see more of this.
For
But
sure. And yeah, to be clear, I have zero affiliations with the Wolf School other than just a fan of this. I can see how this works so well. And to me, not just in my own personal observations within my professional networks, it's a pretty clear consensus that they're a leader in the field, especially here in the Northeast. So props to them and their team for building such a successful culture there.
of the field. Love that. Thank you for that.
Of course.
But for a child to, because I see like how OT can be fit in the classroom, but also let's say if it's OTs in the classroom, but then the mom is getting private OT services, but then the mom is, I want more OT from the school and be put into the IEP.
Sure.
But how is it so that they don't meet the eligibility criteria for the school-based OT service? Why is there a disconnect there?
Yeah, it's hard because I think, given the nature of what I said, it's a broad field. And when I
Mhm.
think back to my interpretation of the why, it's just different training, right? So when occupational therapists come out of their graduate degrees, whether it be master's, doctorate, the skill set is listed as a generalist. And within that, the accreditation of my degree says, okay, I can walk into most settings and I have a baseline education to be able to complete this. Well, I'm trying to think how long I've been doing this now. I've been an occupational therapist since 2017. So coming up on 10 years, there's just been such a profound amount of learning that has happened since then. And a lot of that for me has been independent, where I'm pursuing continuing educations and I can't speak to what each state's minimums are and even what the national minimum is. I usually hit that up by a pretty decent margin, especially being within the private sector. Now, if I'm asking families to pay me privately, I want to be able to confidently say, I've done my due diligence. I am most up to date on evidence-based research and all of that. I've taken specialized training specific to sensory motor and all of these different things. And I think the sensory side of things is probably what gets the most misconstrued, is the rehabilitation side of that. It takes a lot of extra training past that baseline graduate degree. And again, I'm sure there could be a variety of reasons, but if the minimum expectation for an occupational therapist in the public school setting is more degree based as opposed to extra certifications, it could just be a lack of training. Again, there's some vague language, the way that the law is written, where it puts a lot of the clinical interpretation into the provider's hands. So again, it can be a pretty big variance just between even two different school districts.
Yes, because I guess we can use back the example from what I was telling you about the cutting and the gluing. And one of the things that they were saying, because they were like, the private OT is working on this, how come they're not getting that at school? But the whole rebuttal from them was they can squeeze, they can hold, but the execution part of it. And I think you stated something like visual motor, visual planning.
Yeah, what's the why? What is the skill deficit that is impeding somebody from sequencing all of these things together? And again, hard to know based on the example, but even something like that, is it an initiation? Is it the cognitive sequencing? Could this be collaboration with the speech therapist? And thinking back to that immersion model, does it
Mm,
need to be me providing direct service? Maybe, but also I want a child to be able to at least have my mind, my clinical interpretation, so they are getting the repeated practice, even when I'm not in the room, where I'm providing special educators, I'm providing the general education classroom teacher with feedback of, hey, this can be highly individualized, or just providing feedback of, this, in my clinical opinion, is best practice for everybody in your room right now.
So, what I got from that answer is if the person that is doing the assessment, if they don't have enough training, maybe that might be the reason why the child doesn't qualify for OT. Did I get that right?
I could say that's one of the reasons. I
Yeah.
could see. It's hard to know.
But what about from your experience, right? Or from the examples that you have heard that you do understand those examples? What was the reason why a person that is receiving OT regularly, let's say 3 times a week, and then no services at school, can you distinguish the
The outpatient model versus being in the school, you mean? 3 times a week at a clinic or something?
why wouldn't they qualify for OT? Some examples, maybe that can help.
Yeah, sure. I think the language piece within how things are written too. Again, rehabilitation versus adaptive
Yes.
and compensatory. That's where my interpretation is, where some of the, again, I always think back to the sensory motor side of things, the trainings that go into a true rehabilitative sensory program is pretty extensive. So there's a provider that was a mentor to me early in developing my career, and she talks about her sensory curriculum. She typically advocates for 4 to 5 times a week for 4 to 6 weeks. And you can take a few different directions where you might go more parent or teacher education side of things. You might do a little bit more of like exposure, desensitization, all of those kind of things. But all to say, that's a pretty big chunk of time. And even if it is only short term, that specific program was a curriculum that she was following. I can't remember what it was off the top of my head, but it was something that she not only invested likely a lot of money into, but she invested a lot of time into. So I think that's the tie that I make the most to the training piece of it. Is it's not just the accessibility of accessing the training, it's being able to follow through on some pretty high demand rehabilitative principles afterwards. And I think one of the things that she gave me feedback on way back when we first discussed it, this isn't for everybody too. And I don't necessarily know her specifics of what her internal checklist is. For me, when thinking about the outpatient model, and even more specific to the private practice, is I'm not under the confines of insurance. I'm a cash-based model. So it can be pretty specific on parent feedback, and it doesn't necessarily need to be deficit driven or diagnosis driven. There's certain thresholds where I'll meet, hey, they're meeting expectations as it relates to the standardized data that I'm taking, and parents are asking that to be better. And at that point, things can turn into more of a performance model. And even if it's not with me, being able to refer them to maybe a tutor that I've worked with in the past and can provide them with some progressive training, and I come in once a month to consult with them. I think that's the main distinguishing factor. And whether it's tied to, I don't want to say the finances of it, but that's a distinguishing factor I make between the insurance models of outpatient and even the cash-based model of what I provide. Just given some of the clinics that are in this area that take insurance, the margins are pretty low between what they're willing to pay therapists and what insurance companies are reimbursing. So there may not be time for that extra training. And when I was working in more outpatient, not even specific peds, it was 40-hour work weeks. I would say 30 to 34 hours of treating each week. I'm not doing anywhere near that. And by default, I have a lot more time to attend continuing education, to perform a little bit like seated case conceptualization, where I'm asking myself, talking to parents, like, hey, where are we going with this? Let me educate you on what I'm doing so it can be carried over. And again, just that freedom and autonomy parallels back to that immersion model of, it's not, there's a phrase in the therapy community, it's called the laundromat. Hey, I'm just going to drop my kid off and they'll be better in 45 minutes after you work with them. That's just not a reality. There's very isolated skills that maybe that'll work, but it's going to be the carryover in the concepts for the rest of the week of what they're working on.
Oh, 100%. And I know a lot of parents, once they see what's going on with the OT and their child, and they know it's their homework to practice to do that. I understand that families, they do such a great job listening, taking advice from the occupational therapist. But sometimes with schools, during those IEP meetings, they have a harder time understanding because no one is explaining it to them. What would be the misunderstandings that families are having when it comes to the OT eligibility under the IDEA? Because a lot of the times families come into the IEP meetings, right? And then they're still so stuck on, even though they said your child was found not eligible for OT services, but they are like, my child is receiving private practice OT. How come they're not receiving any OT? So if you can please tell us, why is there a misunderstanding?
Yeah, I'm sure it varies too. It's back to what I said with the training. We don't know what we don't know. Maybe I think the concepts within the school setting is the curriculums that I've been provided. Their occupational therapy team is going to be pretty well versed in fine motor skills and handwriting, because that is just such a bulk of what a child's occupation is in the early process. I think in the early education side of things, I should say. So I think that within the field as a whole is pretty well established, and it's cliche.
Yeah, I think you opened up my eyes. You're right, because at school, when you graduate, because I think you said that after graduating, but it's up to the person because you guys get to pick what type of CEUs you want to, right?
And what's the minimum amount too
That they're
within the
willing
school setting? I'm sure they have minimum expectations. If somebody's just meeting the minimum, that's not enough. And I won't go on a total soapbox, but those minimum continuing education requirements, I can't speak to when they took effect, but there was a big bulk of time within the career field where there was nothing required. So if and I'm not saying that people necessarily do this, but I can't imagine that it doesn't happen. If I was told, okay, you finish your occupational therapy training, you have your master's in OT, whatever it may be, and yeah, you don't have to pick up another book or take another online course. I wouldn't be anywhere near where I am in my career now. I'm a completely different thinker because of the information I've gathered in that time. And again, a lot of it was independently initiated. On my website or on my Instagram, I made a public declaration where I wanted to consume at least 200 hours of information on my own, where it may be audiobooks, it may be continuing education, independent study, synthesizing, all of these different things. And I imagine that's at least triple, quadruple what most state minimums are.
Yeah, like you're definitely a unicorn. So I don't find very many of you like that. But just hearing you say this, I don't know, it was like this because I'm so upset, not at you. I'm
No,
just
I get it.
because I don't know if I told you, like they told me they weren't helping my daughter. So then I used to be a microbiologist and then I changed it. I got my master's in ABA and the
Sure.
principal told me to stay in my lane. So then I got my second master's in special education just because he told me to stay in my lane. And then I did the whole classroom thing. But there was a time where I just didn't understand why we couldn't increase the service related hours because I saw the deficit in my daughter and she had 5 brain surgeries. So I definitely have seen it. And what I kept on hearing was she's in high school. The model that we do is consultation. And I'm like, age has nothing to like, this is age discrimination. Why are you trying to push my daughter more on consultation mode when I can clearly see it? But there was a push for me. I was like, I need to get my 3rd master's. Like I was really going crazy at that time. But hearing you is, oh my goodness, parents now may need, in order for them to, I guess, make an argument, have a nice conversation with the school, it sounds like they also may need to know a little bit more about, like you said, the visual planning, like the different parts of OT. There's so many parts, I want to say. It's very extensive.
There's so many. Yes, very much. And it's a very niche field, right? Where I think in addition to all of these things that we talked about, one of the areas that I feel the most comfortable with when I was working out in Los Angeles, I was at a traumatic brain injury clinic, and that was across the lifespan, working with kids all the way through adults. But one of the main focal points was doing visual training with neuro-optometrists and providers that not just help us with the visual perception of how I see and interpret something, it's the literal ocular motility. Are my 2 eyes working together to scan across the room? Even just as we have this conversation, I'm going back and forth between you, my notes, all of those kind of things. Do things move as fluently as they could be? And within that field, so neurooptometry more speaks to traumatic brain injury and more of an incident of that caliber. There's a whole industry where it's either a developmental or a behavioral optometry, because as kids age, things just may not developmentally be progressing the way that we want them to. So I feel like that's very much a strength of mine. And when I complete my vision screenings, specifically in the school setting, I've been given the feedback that it's a lot more comprehensive than what providers have done. And again, it's back to we don't know what we don't know. Prior to that lived experience and seeing the clinical value of the progress that we made out in California. I had a colleague out there. This is the stuff that gets me out of bed in the morning because it's linear, it's tangible. You can see the clear gains that somebody's making. So as I interpret that with the pediatric world, again, things just, I don't want to say zoom in a little bit more from after you graduate from your degree, but it does become a bit more specific. And again, I know I'm very clinically strong with that. I was talking to a provider the other day, and they were talking about self-feeding and all of those things. And I'm pretty transparent, especially in the private practice. My reputation is my livelihood, where I gave the direct feedback. I'm like, hey, the self-feeding isn't a super strong skill set of mine. Let me see if I can support you in finding, because there's just so many curriculums and programs that are super heavily localized training where hopefully I can send somebody on the correct path with the right provider. It might not be me in that moment because, again, I know what my skill set is. And again, as I said, my reputation is my livelihood with the private practice. I want to make sure I'm sending people in the correct direction for that.
Yeah. Thank you. This, I know when you were talking about like the fine motor part of it, can you please tell me in the visual, which thank you so much. And you might have actually already answered this, but just make sure this is good because I don't think a lot of families knew about the whole scanning part of it. I knew because my daughter has a traumatic brain injury. So that's why they added an OT goal because she had to learn how to use her left eye in order to scan. But what fine motor or visual motor skill deficits most commonly support OT eligibility in an IEP?
Yeah, I think it comes back to age-related norms too, and what developmental
Age-related.
stage somebody's at. So it's hard to determine the exact threshold. I can speak to the private practice. I'd say 80% of my caseload right now is in that K-3 range, kindergarten to third grade. And as thinking about the academic expectations as it relates to the public school, occupational therapists will most likely have a good idea of what the expectation is for kindergarten and first grade, whether it's just beginning by writing, just being able to physically form their letters in kindergarten. And maybe in first grade, we go up to writing at least one complete sentences and that scaffolded support. As the academic demands get higher, so do the occupational therapy demands too. So thinking about where the developmental stage is as compared to the masses, it all relates back to that standardized data. And thinking about the IEP process, and to your listeners, I would just really be specific even prior to the testing starting. Again, I can't speak to the legality of this, but I personally have no problem if we send out a signed consent and a family member sent me a message through the team chair or someone else, hey, can you give me the specific metrics that you're going to utilize for the sake of your assessment too? And trying to have that checklist be as comprehensive as possible with not only what those tests are, but what they measure too. So if I'm sitting there as a parent knowing, hey, my child has a lot of trouble with that letter formation, like the threshold I'll often use for writing letters depends on the threshold, is could an unfamiliar adult, so somebody who's not the general education teacher, somebody that does not work with this child frequently, could an unfamiliar adult pick this writing prompt up and make out what it says legibly?
That's great advice for
Yeah,
parents.
I think I have a hard time with the way that some of the public school goals were recently written. I feel like the field is moving in a positive direction. There's been some really solid technological developments. I was recently exposed to this resource that some schools are using now called AbleSpace, where it does use AI to support in the development of IEP goals and all of that. And that to me, it can be like a sounding board too. A lot of the times that I've done contracts, I was the only occupational therapist in the building. And while the skills should come back through that clinical lens, and ultimately as the provider, it's my name, my license, I'm making the final decision.
Yeah.
I was pretty impressed when I utilized that resource because I can plug in pretty specific information and it regenerated things that, again, meet the expectations of the legal requirements in the state of Massachusetts, but also it was a sounding board between two clinicians. And again, at the end of the day, I get final word. Resources like that, I feel like talking back to progressing with the field and staying with the times, like that's the epitome of use this really smart technological tool as a tool. And it shouldn't be a crutch, but something that can support with a report writing and IEP writing. Like that to me is AbleSpace, yes.
AbleSpace. And that's something that the schools
will purchase it, yes.
purchase. Okay. I was like, maybe school can purchase this for families.
Yeah, I can't speak to the price based on how well structured it is and how efficient it is. I imagine it's expensive. But again, like not to dive too much into AI and all that, but more so continuing education where the field is going, like use these tools to have the most productive client outcomes.
Yeah, but I think also it might even help the occupational therapist because there have been some reports, like in progress, where they're even describing things that the child isn't doing. But it might be because hopefully they don't do the whole copy and paste, but they were thinking about another client, thinking it was that one. And maybe if they do use AI, they can just speak, describe the client, and then more
I
appropriate
was
goals instead of
I
using the
was
same.
during my experience, I was profoundly impressed by how individualized I can make this. And it's funny. I was talking to one of the senior therapists who I worked with where she used it like bullet points of make goal for blah, blah, blah. I can't even remember the specifics, but I was intrigued by that because I was like having a conversation with the tool as if you and I were talking like, hey, here's Cody. He's in third grade. He's currently having trouble writing his name while staying on the lines. He has a crazy amount of modulation of pressure when he's utilizing his pencil. Sometimes it'll break, all of those kind of things. Can we come up with a handwriting goal to support this? And
Oh,
it
awesome.
was, again, they give you a few options, and ultimately the one that I thought was the best fit, that was my clinical decision, but it was a sounding board at minimum to
You got to
give it.
refine it even more.
Yeah, given the AI, it's going to have some concept of whatever the age-related expectation is, but also give me
Created.
some insight on where research is going. Like I asked it the other day, I'm like, what accommodations could I use for this? And I think I have my go-tos, as everybody does. While I have a formal bank of things that I'll typically advise on, it's that protected time. When I have 20 minutes just to sit on accommodations when I'm doing a report, I can just come up with so many different things that can be supported across so many different settings. So again, a lot of good tools out there, and I'm sure it's not just limited to that. That's just the first one I can think of.
Thank you that you definitely gave families an idea what can be out there, what schools can be using, because sometimes they're just not satisfied with the goals. They're like, really, this is the same type of goal that I've been seeing every single year. So it's
Right.
kind of nice that there's hope for the future.
Yes. Yes.
Yes. We'll be moving on to the sensory and processing self regulation. And my question is, under what circumstances do sensory processing or regulation challenges qualify a student for OT services in school?
Yeah, and I think in my experience, it's been tough, like reading through previous IEPs, like if I'm picking up a 3-year evaluation, and even with my evaluative process, when I look at the evaluation, all those subsections of OT, yes, the sensory motor is a pretty big component, and that relates back to what the teacher's reporting, what I'm seeing when I push into the classroom and do a clinical observation. How does it relate back to the other things that fall in the occupational therapy web, the visual motor, the fine motor, all of those? And again, I'm not saying it's right or wrong, but a lot of the reports that I've seen and a lot of the justifications of, hey, they tested within normal limits for these other things in our scope of practice, it's hard to justify seeing a client just for the sensory motor when, by definition, legally, the rehabilitation piece isn't necessarily a part of that. And as I said, it's pretty extensive training to do sensory motor rehabilitative training, where I imagine the vast majority of generalist occupational therapists, so somebody who just comes out of school or that's their primary education, they just don't have the knowledge base of what could be done as a restorative concept.
So when you were talking about rehabilitative services, that sounds like that is more private OT and that is not the scope of school. Therefore, that is why they are not getting the sensory processing done through the school because they have shown, I guess, how they're similar to their peers. But even though the parents have seen that they're not at where the parents would like them to see it. Is
Yeah, and I think again, I'm not in the legal side of things. The way that the clinical interpretation of occupational therapy for me might be a little bit different. But if you look into some of the sensory motor programs, one of the main ones in the field is called ASI. It's Air Sensory Integration. The modules and the training that goes into that, it truly is like having another degree. It's pretty extensive. It's a lot of hours of coursework. And then similarly, like the Star Institute is very much another leader in the field, specifically for sensory integration. They have, I can't remember what they call their credential. It's something like the mentor, like a Star Institute mentor or something of that. I think again, the legal interpretation is those are just seen as very specialized programs. And it's similar, the comparison I have for another niche field within occupational therapy, it's more similar to that of like a certified hand therapist. A certified hand therapist is an occupational therapist by trade, but I don't even know what their clinical hours look like to achieve that almost second degree, but it's pretty extensive. And again, I just don't think the field is there to be able to offer that in the public schools.
So what is a certified hand therapist? I want to say I did hear about it.
Yeah. Yeah. And
What is
I think, again, not my niche area and like the limited
yeah.
exposure that I have had to. It's pretty extensive. A lot of different trauma related injuries where somebody either broke their finger. The hand can just be super specific on how we're rehabilitating. It's not just bones and muscles. There's what we call pulleys and all of these other small little intricate things that can make the rehabilitation process a little bit more challenging. So they'll work across the lifespan, but when I think of a certified hand therapist, I typically think of more like a workers' comp injury where somebody, we don't need to get into the gruesome details, but we think like construction workers, if they had an injury on the job and they need to return to work because they're not able to grasp their hammer again because it was injured. So to my knowledge, it's not super specialized in that of the pediatric world, but again, it's a very niche skill set because of the complexity of the hand. Similarly, the sensory system is super complex, and while again baseline degrees give us that general education exposure, it takes a bit of extra time to really understand how to rehabilitate that.
Then why are sensory needs alone like insufficient for OT eligibility? What additional data does that parent need to ask for or request in order to get the eligibility for their child?
I think it's hard because, and I don't want to keep deflecting into more of the specialized programs, but even some of the reports that I saw, once I had a pretty solid foundation of the sensory system, the collaboration of the outpatient model with the style of schools is, again, all these different training programs, the ones that I'm familiar with, somebody else might have a completely different skill set. So it's not to necessarily deflect into get more private evaluations. So this was like a rite of passage. I just received a referral for a client in the greater Boston area, and the family actually flew to Denver to complete the STAR Institute evaluation process. And as I'm reading through this report, it was well over 50 pages in the best way. And it was like profoundly specific. I didn't even ask how long they spent out there. It must have been weeks, just based on how much specific information was given from, again, the hub, the leader in the field for sensory processing.
That information so we can put it in our link so families can know about it.
Yes, remind me for sure. I think, again, knowledge is power, and like knowing the resources that are available from, again, not just local providers, but the big players in the community, whether it be sensory or we talk vision, all of those things.
Yeah, because what I'm hearing from you is that OT is just not fine motor. It's like more than that. What I'm seeing at school, they're just seeing the fine motor, but how can, you know, how behaviors can be
totally.
for academics, right? But how come they don't see, like, for me, it's just really hard. For me, it's just really hard to comprehend. Now I'm seeing this as a behavior analyst because typically when I work with an occupational therapist or when we work together, I need to hear from them about the sensory diet. I need them to tell me because that's their field. I'm just implementing what they are saying and then using how to adjust the environment to make sure we have better outcomes for the child. But over here at the school, if they're saying they're not really caring about this whole sensory processing and then they're just putting behavioral supports, I'm getting really nervous about that. So then how can the school differentiate between the sensory needs and then behavioral supports?
Right. And both can be true. It's the collaboration. I think you said it best. Like most people, whether it be parents, even other providers, school districts as a whole, they likely have a preconceived notion of what is that scope of practice for occupational therapy. And I can't speak to the legality side of things if anyone's ever listening that wants to open up a seat at the table for me when some of these things get rewritten. I think the occupational therapist's voice within educational reform as a whole would be infinitely helpful. And I'm biased, but I've seen so many of these concepts of sensory motor strategies for regulation, attention, all those things work in my career. And I think when there is that preconceived notion that OT is just the fine motor, it can really be limiting. And
Very
again,
limited.
I don't want it to necessarily be a top down thing where it needs to be legally rolled out of like, hey, this is the expectation of how all occupational therapists can be. But I think thinking of how to challenge occupational therapy peers or allied health peers of like, hey, what are you finding that is the hottest research that you've seen in regards to whatever it may be? Thinking back to my graduating class, there's one colleague that I touch base with very frequently, professionally collaborating, bouncing ideas. That's crazy in concept that it's only the two of us. Everyone's branched off to do different things, but
Yeah.
I can see within, not even just limited to public schools, I can see within the career field a certain degree of complacency that comes about. And again, private practice, I'm a team of one. Like I need to be good at what I do or I don't get clients, right? That's just the nature of it. And I don't want to necessarily associate it to the contrast of a cash-based model versus the public school setting, but just thinking about resources and all of those things. Thinking back to my model that I discussed, in my perfect world where occupational therapy rules supreme, right? There's an occupational therapist in every classroom, and people will say that's an absolutely ridiculous concept, but that's my perfect world. And I think wheels move slowly relative to some of the other allied healths. Occupational therapy is a newer field, and research and evidence-based practices take time to roll out, but the hope is the leaders in the field can continue to advocate on our behalf. So school systems, the outpatient settings, whether they be cash-based or insurance, it's just a higher standard for care.
Yeah.
Care is a very medical term, but that's just for providing services.
Maybe my face is not telling you, but I'm thinking 1,000 miles an hour right now because I'm like, you've just been so honest. And I really want to thank you for that because a lot of the times I want to say that occupational therapists from the schools, I know that they must feel like overworked, burnt out, but a lot of the times parents just want to know why aren't they getting services? And now you made it clear in my head that it has so much to do about their training. I don't know if I told you this. My daughter was misdiagnosed when I knew there was something wrong with her at 7 months old. I knew there was something wrong. Told me, took them to the doctor, and they were like, please stop calling. There's actually sick kids here. And they just saw me, this young mom that was bothering their, oh my goodness. We lost the window of opportunities. They didn't look like seizures. So then at 14 months, she had a drop seizure. And I was like, I thought there was just something like motorly wrong. Maybe her neck was, something was wrong. The thing that they told me that it was Tourette's, and they said it was night terrors, but it was seizures. I was not going to mess around. When she dropped, I was like, I'm not going to go here. I have to drive 45 minutes to talk to other specialists. So then I went there. That's when they told me. But then what was so weird for me is that no two neurologists were telling me the same thing. But I didn't like how they were saying it. Something just fell off. I was like, I'm going to stick with my gut. So then I went to Minnesota, Illinois. I just went all the surround. I flew out to Johns Hopkins. And then from there, I just really went throughout the whole East Coast, just finding the right provider. I found the right provider. I live in Maryland, but we go every 3 to 4 months to New York to see Dr. Bluestein, who we love. But now feels like it also has to be done like this. I'm not trying to stress out any parent. It seems like we have to go to this extent to find the right provider. The school provider may not be the one that will help you guide you because they're burnt out. And it also seems like we have to be very cautious who our private OT is because they may not be trained.
I think within the private sector, reputation goes a long way, especially you can Google, not just my name, you can Google all these different private practices and all that. So if somebody's not adequately trained on X, Y, and Z, that's going to become even more apparent, right? And I think in regards to your experiences, I feel like a broken record when I say this to a lot of my families that I work with. Your daughter is so lucky to have you as an advocate. And I think advocacy goes a long way, and continuing to try and unearth what is truly going on like that. I don't want to draw parallels to all that you went through. Like I've got two cases that really stand out to me that really conceptualize, okay, this was beyond my scope of practice. I didn't know what is going on. Keep asking. I received early in my pediatric career, I received an evaluation, handwriting referral, all of that. We're doing the evaluation process, and the child's testing pretty high across the standard metrics. And the teacher who I was collaborating with was a formal education teacher. She's like, I don't know what's going on. There is some disconnect and I just can't place it. So like we're talking through it back and forth, relay the same thing to the family. I'm like, hey, we don't really have the answers. Keep pushing though. So they ended up switching primary care providers. They go to a new doctor, and I get a call from the teacher a few weeks later. They're like, I don't even know how to describe this, and I can't believe that this was missed. But the new provider said he has so much earwax in his ear, they don't think he's heard anything for the entire academic year. And it was like April by this point. So all of that information was just not in one ear, not the other. It was in one ear and then deflected back because this poor kid had earwax. And again, that's not something I would have ever checked for, but that just totally opened my eyes to, well, okay, like the communication between other providers goes so far in this career field. Pretty similarly, and this was super recently, I was doing an evaluation for one of my private clients, and the mom was telling me some of the medical history and all of that, where, long story short, they were working with an ear, nose, and throat specialist. I ended up going to a specialized, I'm trying to even remember the language, it was a specialized myofascial speech therapist. And basically, within that therapist evaluation, they found a super unique cleft palate where the primary ear, nose, and throat specialist had no idea what that was. We ended up transferring them to another provider. They got scheduled for a pretty routine surgery, and it completely opened up the airway. The kid wasn't smelling before. And again, it was all just figured out by going another direction, getting another opinion. So all to say, the advocacy goes a long way. If, as the parent, you're seeing something that you don't think other providers are.
Yes, they don't know about, and then they learn about it. Wow, I did hear about, I can't pronounce that, the
the myofascial speech therapist. And again, myofascial research, I'm sure there's specialists for occupational therapy too.
I know that Hallie Bulkin, I don't know if you follow her, but I know she does classes to teach OT and SLPs about that. So how I knew about that, but it's so funny because I was like, yes, I am hearing it. I'm so happy that I'm hearing more of it. Provider.
Yeah, I'm pretty transparent. Like, I don't know what I don't know. I'm learning on the job every day, but there's also this wealth of information out there. Yeah, given the nature of what I do, concierge style service, I'm in the car a lot, and don't get me wrong, Friday afternoon, music every time. But especially during the week, I see part of the duty I have when I'm paying myself for the practice that I'm performing is the education side of things. So I've got an audiobook pretty much going nonstop on whatever it sparks my interest or what I may not be as clinically strong with. I find it just fascinating. Like with occupational therapy, I still feel that I preserved a lot of that medical model within my training early in my undergrad, exercise science, movement, all of those things, like the kinesiology concepts, all of that is so cool to me. And then you get into the higher level neuroplasticity, neurology concepts with play-based training. I think it's hard to not be excited about this field. I can't remember if I mentioned last time we spoke, but my sister's also an occupational therapist. So she's the baby of the family. She just finished her doctorate degree, so she went one higher than me. But in her experience, in her training, she was doing some clinical observations of me way back when I was working in Boston. She's like, your job rocks. I'm like, yeah, it really does. And I feel like if you look on all the online forums, like what's one of the most satisfying career fields, occupational therapy is usually at minimum top 10. And I think, again, it's a privilege to work in this field. So I count my blessings for that frequently.
Yes, I'm so happy that you landed in this field, in your field, because we need more advocates for families, for our children, for the participants that are using your services. One of the things that I really need to ask, because you said like kinesiology, and I guess when you said that, it made me think about the daily living type of skill.
Sure.
which brings us up to the next one, which is the functional independence and daily school routines. When we ask schools about the whole planning of it, being more independent goals, they're like, it's not curriculum based, but for students that are not diploma based, they're certificate based. For them, that is their curriculum. So how come they're not focusing more like on the functional independence side of it? So I guess my question would be, how does a functional independence, such as managing materials, organizing work, or self-help skills, how is that factoring into the OT eligibility?
I feel like the broken record sentiment is restorative versus compensatory. In my opinion, self-care is very easy to just build in a compensatory strategy. And I'm not saying that's right or wrong, but I can see how, when we think back to function.
For the compensatory?
Sure, a compensatory strategy, and I think a really classic example would be tying shoes. Thinking about the task of physically completing the bunny loop, crisscross, all of that, the precision aspect of tying shoelaces is really hard. Thinking about the ultimate task is to be able to put our shoes on and walk, right?
Yeah.
So
Yeah.
a very easy compensatory strategy would be, oh, they can just wear Velcro. Thinking about the holistic person, that's fine and dandy for our littles, thinking preschool, kindergarten, all of those things, but it can be a little bit stigmatizing if you get to a certain age and you don't know how to tie your shoes and all of
Or
those
they don't want to wear
things.
those shoes. They want to wear the other style of shoes that
Of
the other kids
course,
are wearing.
and I can't speak to the major reform about it, but I think just looking at the language of idea and all of that is very much the function. Let's just make a functional environment. And the way that we can do that is by manipulating the environment, changing for the Velcro. That's the foundation of the self-care, pretty similar to zippers and all of that. Oh, they can't do buttons. Well, maybe they can just do snaps. Again, I have my own opinions about that and why I would much rather a restorative concept, but it's just not the way that the language is written. And from a legal standpoint, I don't want to say that people are taking it as an out or deflecting, but that's just the reality of what's the quickest fix.
You're using terms that I want to make sure the families understand, because I want to say this is very important. So for the restorative strategy,
restorative would be the physical process of training or retraining the skill. Restorative would not be adaptive. Typically, compensatory and adaptive go together, where I'm going to adapt the environment so they can compensate, still be functional, and perform whatever task. A restorative,
so compensatory strategy.
Yes, and that would be your accommodations within the IEP language.
So the compensatory strategies, those are the accommodations, those are the adaptive skills. And then the restorative
is being able to I say retrain again. I spent so much time in the geriatric community, but learning for the first time, it's the physical training of the task, gaining the skill. We're going to develop a pincer grasp where anybody's listening, I'm just holding up my thumb and my pointer finger to be able to pinch my shoelace and then know what the cognitive sequence is to make the cross, to make the bunny ear, and have the fine motor coordination to sequence that task. So rehabilitative is more of the training of a skill to try to make them independent without supports. Compensatory is more adaptive, compensating. And again, I can't.
It's the cheaper of the two.
Yeah, I can't speak to the why. I think I want kids in the classroom too, right? So it's tough for me to interpret what the why is. I think it's a big deal to take kids out of class, but at the same time, ultimately is the quicker fix, which I don't necessarily agree with that part. That's where I think a lot of your questions went, where it's more of the divide of what bucket does it fall in versus the outpatient versus in the school. So I don't know. Well, there's just not enough hours in the day, right?
Oh, yeah, no. But if they would have done more, like for my next question, OT related skills, when they are related to the motor planning, sequencing, initiation, I understand that part. If we focus on those, just those that I've mentioned, but if they would have practiced it on different skills, on different tasks, right? If they would have just practiced those domains from the very get-go and not just looking for, oh, how can I accommodate that? Or how can I find an adaptive tool? But if you would have just taught them that part, they can generalize that on their own, because by the time they get into high school, if they've only gotten those tools, which we're mighty thankful for, but in the real world, out there in the community, those tools might not be there, but they've never been taught how to do like the motor planning or the sequencing or the task initiation. So I guess my question
Yeah,
is, how can we get the school to understand that we do need to focus on this? Yes, accommodations are great, but how
right.
can we also work on this part?
Yeah, the earlier the better. I've spent the
Yeah.
majority of my career in that early elementary, and I very much see everything that we've been talking about as the foundation to set up the more complex tasks of the executive functioning and the independent living, the metacognition that goes into reflecting into one's daily schedule and all of those higher level concepts, thinking exactly what you said, past just high school, right? My main sentiment is the earlier the better. And if there hits a certain point, thinking back to our shoe tying example, if we're just going to provide Velcro, at what point do they learn? And again, I don't necessarily have an answer to that other than the advocacy of the earlier the better.
Yes. Can I ask you a question about
Please.
the task initiation?
Mm-hmm.
Because I'm thinking about a case. Actually, it's the same case that I was telling you about.
Yeah.
The one that can like do the glue part, can basically do this rhythm with the scissor, but not actually cut the paper, or can write, but is it eligible? It's questionable. But they can use the tools. But all of that is so much prompting, so much support. But what we were just talking about when it comes to the motor planning, but really the task initiation, have you seen in IEPs, have you seen examples of students actually getting eligibility or goals that just focus on task initiation? Have you seen that? I have seen it, but I don't know if is this the norm or is that not the norm?
I think I would loop it back to whose bucket is that going to fall into? It could be
Yeah.
within the scope of occupational therapy for sure. I think my logic is if something like initiation is a little bit challenging, I'd be very surprised if that is the only isolated skill that a child has difficulty with. With that said, if I'm sitting in an interdisciplinary team meeting thinking about initiation, who could take on that role? It could be the BCBA, it could be the speech therapist, it could be the
Especially.
occupational therapist. So my concept is very much like the knowledge is power. What is that conversation looking like in the collaboration amongst interdisciplinary team members? And that all should be happening within the confines of the IEP meeting, but even challenging that of just tell me more, like what is your logic for this and why is it not you, and who at the table is going to take on this skill.
If it's not
It,
you, then who else is going to focus on?
and I again, I feel pretty confident in my scope of practice and my skill set. I've been at an IEP meeting that had 18 providers, and when it's diversified between so many different faces, maybe we're not all on the same page of how we're delivering instruction. How can we have, I don't want to say simplified, but more is not always more. I would much rather the most highly trained person who is really good at that specific sub skill, whatever it may be. Again, we'll take task initiation. So if that's me at the table, totally, I can advocate for what I know. But if I am talking back and forth with the speech therapist and hearing what the data is suggesting, but some of the other clinical observations that we're making, it's not necessarily deflecting who should take them. Oh, I don't want to touch this case. For me, it should be I firmly believe you are more adequately trained to do this. Or if you're going to take this, I'm going to take this and we're going to collaborate on this. So it's sorting it into the buckets of who is the best person for this job. But even if it's not direct instruction, if I want to see the table and I feel like I can make a difference, I'm really asking myself, does this need to be in the more traditional pull-out setting twice a week for 30 minutes? Or can I immerse myself into the classroom where I go in every now and then to support with X, Y, and Z as an environment? Can I collaborate with the special education teacher to facilitate this when they're in special education 5 times a week? So for me, it's very much prioritizing the allocation of time for it. And even if it's not me providing direct service, like I want the child to have access to my brain too, because I think when you do collaborate, that's when the most successful schools that I've been in, it's when the interdisciplinary team has really clear concepts of what everybody is good at, what everybody is the most comfortable with, and they can confidently say, hey, this is the absolute best plan for Cody, and here's why. And again, challenging the why. So I think within the IEP meeting, cliched expression given it's a school, but I want everybody to have the heart of the teacher, where the occupational therapist is thoroughly explaining the sub skills that are within my lens, my scope of practice. So there's just a very clear concept of what my role is, or at least what my interpretation is. And as far as individuals go, I can't say where everybody's at, but I think that would be my challenge to your listeners, is at least have a very clear idea of what everybody at the table interprets their role to be. And then from there, knowledge is power. And there's a lot of really good resources out there where advocates, attorneys, and I know not everybody has the means, but there are a lot of people in the field who have a much better concept of the legal aspect, the holistic legal application than I do. Like, I know my scope, but I don't necessarily know the intricate details of every single piece of the educational eligibility as a whole.
Yes. Thank you for all that information. That was really good advice. I do appreciate how you're making, because I'm also a parent, like us parents understand more about the scope of things. So for OT, definitely made me realize that I already knew this, because every provider is different. Every medical provider is different. Like I told you for my daughter. So it has so much to do about who is in that table. Also, I just need to ask, because I really don't know these answers, because I'm not an occupational therapist. Can you please inform the families what type of assessments carry the most weight in OT? In the OT eligibility decisions, the standardized testing, observation, teacher input, or functional checklists?
Sure. Yeah. And what it should be is a combination, for sure. As the experience, the first thing that comes to mind is that experience that I had with the little boy who had so much earwax in his ear he couldn't hear anything, right? Like, the clinical data to me said, okay, he's really strong with visual motor. I have 0 fine motor concerns. Sensory rating scales within my clinical observations, I didn't see any characteristics that were within the more traditional over-responsive or under-responsive sensory system. For me, it was a bit like playing detective, and it wasn't just me, it was a whole team of us, but playing detective of what truly is going on in this case. And it's not always going to be a quick and simple fix, taking earwax out of somebody's ear, right? But it should be a healthy combination of standardized data, clinical observation, collaboration with teachers. And for me, it's not just general education. I want to know, especially within the sensory lens, I want to go do a clinical observation during PE. I want to go into the lunchroom, recess. All of those unstructured times give me a lot of really solid information too, because I can't remember who said this to me recently, but I was in an IEP meeting and the teacher was like, how do they describe it? They're like, yeah, I think he does a lot better with adults because kids are just too unpredictable for him, like other kids. And I think that makes sense for a lot of kids in those unstructured play times, as opposed to the general education classroom. They know the flow, they know the expectations, and when it's teacher-led, there's a fair amount of structure that goes into that. I've seen recesses where there's 28 kids on a soccer field when it could probably realistically only hold 15, and conflicts arise and all of those things. That's solid clinical information for me too.
But this is actually really good information for families to know then, from what I'm gathering, is if there's an OT assessment, one of the requests that parents can make is, can you please go in an unstructured environment for you to do your observations? If you had because hopefully they do all across all environments, but what if it was only during structured time? We want to know that.
For sure. And I don't always get a list of parent concerns prior to an IEP meeting. That's part of the Massachusetts IEP process, is there's a whole section dedicated to parent concerns. But when a consent is sent out, signed and sent back, like for me, that's helpful context to like, hey, here's what we're seeing. We're seeing is a little bit difficult. Here's what they're endorsing. And again, depends on the developmental age, so many things, especially for the sensory rating scales. I think the standardized measures, when kids are around 13 years old, they can start to do a self-questionnaire too. And
Mm.
having the child's voice in that too gives me a lot of good information. Where if the parent's saying, hey, every night that they're coming home, they're endorsing that their hand is sore or X, Y, or Z about handwriting, whatever it may be, that for me holds some weight of, okay, I'm going to pay extra attention to that because it's an active complaint from the client who's experiencing it.
That's great. This reminds me, I do have, it was like a fourth grader, and his mom wants more OT for him because he would cry. He would cry like his homework. He says he has a hard time concentrating,
Mm-hmm.
writing the sentence. But when you see him type, oh my goodness, he can type. But
Sure.
when it goes to him actually needing to do it, mom said it's so painful that he's crying. So she's going to bring this up to in the meeting, but they said that, oh, at school he's just having a lot of behaviors, but mom sees all the emotional side at home. So I think just having that communication, it's actually not behavioral side, it's more than that. It's something much more internal than that. So this is actually really great advice. Listen, I need families to hear from you. We have a part 2 that I'm definitely going to ask you a lot more questions.
Yeah, please.
Yeah. But can you please tell us where we can find you? Can you please tell us about your private therapies? Because there's going to be families that are like, look, I just learned a lot from you. I really want to work with you, because they just have questions about the school. And they sometimes, if trust is broken, there's history, there's a reason why they don't like the school system. And they just need guidance from a professional that does understand. So can you please tell us?
Yeah, of course. And I think you hit the nail on the head. Trust goes a long way. And whether it's occupational therapy specifically or across all of the disciplines, like find the people that you trust. There are a lot of good providers out there. And again, I feel very privileged to live where I live in the greater Boston area. This is such a hub of medical information and a lot of really high performing therapists. But with that said, I've been with the private practice 3 years now. And it took me a little while to find my people too. When I think of my interconnected network, it took time and going to several meetings and hearing other providers and how they're talking about it to determine who my network is so I can confidently refer to. With that said, more information about me, my website is emergingkids.org. On there, you can find the links to all of my socials. I'm trying to get a little bit better. I've rolled out a few just like quick educational resources on Instagram. I think one of, again, amongst many pushes doing things like this, the community education, all of those things, I want to get better about providing just generalized concepts on the online platforms and all of that. So hopefully by making it a public declaration and knowing that I'm going to have your listeners turning their head to find me, I'll be a little bit more adamant about making that. So yes, emergingkids.org provides very brief oversight about into the specifics of what my private practice will offer. But again, contact info is on there. We'd be happy to talk to some people about what just being a sounding board for what they're experiencing. Given the nature of the field, it's highly individualized. And over the course of the evaluation or over the course of our conversation, I feel like I dropped up, well, it depends a few times. And I feel strongly, I individualized education plan. It should be highly individualized, right? So case by case, child by child, if there was a one size fits all model, I probably would be out of a job.
Yes. But do you just work with families in Boston, or are you open to working with families in different states that want to have consultation with you across states? But maybe it can be like a parent model. I don't know if you also do virtual OT where the parent will be, I guess, a technician or your OTA, and then you would tell the parent, but you would see how they are. So I guess it would be like a parent coaching OT.
Sure. So I haven't provided too much teletherapy over the course of my career. And obviously there's exceptions for everything, but I think a lot of the things that I'm trying to roll out really do need to be in person. So in regards to treatment, I'm pretty firm that it's in that setting. That's actually a really good question for the legal standpoint of crossing state lines. I think the only parents out of state that I've collaborated with, I do have a professional license in all of them, being New Hampshire and Connecticut. So I've got most of New England covered.
This would be like private pay where insurance wouldn't. So your certification.
Yeah, let me do a little bit of homework on that because there just is the professional license regardless of insurance. So I actually don't know, but I think that is a nice piece of homework for me when we sign off here to see what is my scope of practice in that role.
Yeah, it's just that you've been so open that I think it's just good for families to know that maybe they can contact
Sure.
you.
Yeah, I think again, just my gut tells me parent education probably would be okay, but again, I don't know for sure. So before giving a declaration on that, let
Yeah,
me do a
because
little
you
bit
can.
of homework. When I first started advertising and doing marketing for the website, somebody Googled me. I think they were in Atlanta, Georgia, and they were former military family as well too. So like, hey, we're near this base. I can't remember what it was. And I was like, as a former Air Force member myself, I was like, oh, I got you. Let me see if I can call some people. And I was able to find a clinic where I was like, oh, okay, this one seems to only be a few miles away. I only had a 15-minute with the provider, but they seemed to get it. Again, even just
Look at you.
being able to vet things like that was easy enough for me to do.
Do you remember that we were talking about the video modeling?
Mhm.
I just love that you're so student focused. I just love that you were so on that. But I was thinking more like you can do the video modeling for the families, meaning
Sure,
like you show them and then that's how they can work with their child.
totally.
So I was thinking that's the way that families can seek for your advice because they're like, look, at school, I can't work on X, Y, and or they're not working on these goals because they don't see it that it's useful. But I know that it's useful. How can I teach my child how to cut? Start off cutting really small, but maybe we need bigger ones and we need thick lines for them to follow.
For sure.
But a provider would give them that idea. Maybe they wouldn't know to start that way.
For sure. And what I can do too, again, I've got to be better on the socials. I know that. I can provide a list of providers that I follow that I found to be pretty helpful. Again, off the top of my head, four big players in my professional journey has been the Star Institute. This is all pretty specific to the sensory world, but the Star Institute, which is air sensory
Oh yeah,
integration,
awesome.
Sensational Brain posts a lot of really good information. And then the other one that I feel like has a really solid online presence, specifically Instagram, is Harkla, Harkla, I believe. I feel like they're probably the most frequent posters, and they do a lot of work with like primitive reflexes and all of those foundational
Oh,
neuro concepts.
oh my goodness, we're gonna talk about that
I
in
was
our
gonna say
second
we have so many things to
so
talk
much.
about. It's
Yes.
crazy. And I was trying to be, when going over my objectives for the day, I was just looking through everything. I'm like, there's so many different directions we could go for this. And at minimum, this is a great trial. This is my first podcast appearance, so it's a good trial run to see how things flow. And again, it's a testament to your ability to guide the conversation. But there's just so much information to be had out there.
Yeah, so much. But you really, I'm telling you, you really prepared the families because sometimes families, they trust the professionals, they trust the school because they're like, oh, they're the professionals. But then you kind of
Sure.
gave us the reminder that not all providers are the same. Not everyone is the same,
Yeah.
so
Yep.
we have to see them that in that light. So I really do really want to thank you. And thank you so much for taking the time today. I'm ready for our part two. You just
Yeah.
let me know what, yeah, we need to be
Yeah, we'll
together.
coordinate.
Okay, and then please don't forget to send your website so that way I can put
Yes.
it in the notes so that way
Perfect.
they.
I'll send some of those resources.
Thank you again.
Of course.
Take
All right.
care.
Talk soon.
What you heard today is that occupational therapists may work from different frameworks depending on their training, experience, and the system they're working within. Some approaches focus on compensatory or adaptive strategies, changing the environment so the child can function. Others focus on restorative or rehabilitative work, building the underlying skills so the child can become more independent over time. That part that Cody explained for me definitely helped me understand a little bit more about these different approaches. So understanding this difference helps explain why a child may receive private OT but may not qualify for school-based OT, even when the struggles are very real for the families. If this episode helped you, please like, share, and comment, and make sure you follow Starting with IEP so you don't miss any future episodes. For deeper support, step-by-step guidance, and parent education, please visit us at www.startingwithiep.com to explore our courses, programs, and advocacy resources built specifically for families navigating the IEPs. We will definitely be inviting Cody again because he has so much to say, so much to teach our families. So I'm really excited for our part 2 of this conversation. But like I said at the end, you guys can definitely contact Cody at Emerging Kids Pediatric Occupational Therapy. His website is www.emergingkids.org. And on his homepage, it looks like you're able to contact him and set up an initial consultation. It definitely has his time availability that you guys can chat. It definitely talks about him as the founder. And also he does list the services that he provides are social and emotional, neurodevelopmental vision, handwriting, typing, sensory regulation, motor development, lifestyle and self-care. This all has been so great to hear from him because he's definitely giving us a different lens, right? Especially as parents, because we're not occupational therapists. I'm not. So it was so great to pick at his brain and definitely get more information about how the school views it and then also him as an occupational therapist. So please check him out at www.emergingkids.org. And I'm super excited to talk about part 2 with him. So stay tuned for that. I will see you in the next episode. Bye.